This morning's session, titled Cauda equina syndrome is not the only spinal emergency. We've got two speakers this morning. The first is Tom Watt, a consultant physiotherapist at Salford Care Organisation, and then Mr. Rajat Verma, consultant spinal surgeon at Salford Royal Hospital and Royal Manchester Children's Hospital. We'll take questions at the end, and if you do have a question, could I request that you please use the microphones as the session is recorded, so it makes it easier for us. Thank you.
Good morning. Thank you, Elaine, and thank you for inviting us to speak today. My name is Tom from Salford Care Organisation, a consultant physio. We just want to spend a bit of time today going through some cases of non-cauda equina presentations to come through. I think cauda equina is very well documented and discussed nowadays. We want to go through some alternative cases that may well be coming through into the emergency department. No disclosures. So I wanted to start with a 67-year-old gentleman who came into A&E with a one-week history of neck pain that was felt to be mechanical. It was aggravated by lying down. He had a normal neurology and he was apyrexial at the time. His past medical history included emphysema, and he was prone to chest infections, but didn't have any change to sputum load or colour at presentation. His bloods did show a slight rise in inflammatory markers with a high white cell count, neutrophil and CRP. Though a urine dip was negative. A chest x-ray showed some left basal consolidation, but he didn't have any clinical signs of a lower respiratory tract infection. So the question was put forward, is this coming from his neck? And an x-ray was completed, which was reported as degenerative changes only. He wasn't started on any antibiotics for this. He was sent home and safety netted and advised to come back should symptoms worsen. And he did come back 1 month later with this worsening of his neck pain and right upper limb neurology, fever, weight loss and night sweats. On examination, he did have a significant weakness on the right-hand side with normal sensation, and the MR scan hopefully shows on the screen as a severe discitis at C4-5 with bony involvement and cord compression. He went on to have blood cultures which showed a Staphylococcus aureus infection, and an echo showed mitral valve endocarditis. Unfortunately, 2 days later, he developed septic shock and died. So the learning points from this case is that spinal infection should be considered with those with neck or back pain, raised inflammatory markers, and not an alternative source. Plain film imaging is not recommended, as early stage infection may not be picked up. And if clinical suspicion is low, there should be strict safety netting and consider interval imaging, interval biochemistry, either via your own services or via general practice. My next case is along the same theme, I'm afraid. A 72-year-old female who admitted with collapse, hypoglycemia and anemia. She did have chronic back pain, which was worse on admission, potentially due to the collapse. She did report some general weight loss and had a past medical history that included chronic kidney disease, type 2 diabetes and recurrent UTIs. Again, her neurology was normal on assessment, and she had a mild raised white cell count and CRP. She'd had a previous MR scan a couple of years prior, which showed some degenerative changes, which was managed conservatively with non-steroidals. The medical team arranged a CT tap to rule out a malignancy, and they didn't find a malignancy, but did find this change within her spine. An MR scan was then subsequently completed, showing this T11-12 discitis, bony involvement and kyphosis. There was also an epidural involvement that caused some moderate canal stenosis and cord compression. She went on to have a surgery in the form of a posterior thoracolumbar fixation about a week later. The learning points from this case is that even though white cell count and CRP are only marginally raised, there could well be a severe infection within the spine. She had multiple risk factors, which I'll come on to later, for a spinal infection. And she went on to have surgical intervention due to the instability, pain and progressive deformity and mild cord compression. So my talk is generally about spinal infection. The incidence is rising, and that's partly due to our ageing population, but also some iatrogenic factors, including more metalwork being put into patients, renal replacement therapy and immunosuppressive medication. It's also felt that because of our improved diagnostic techniques, we're picking up more of these cases. Importantly, there is an increase in litigation in these cases as well. As Lisa talked about on Tuesday, our claims for these patients are going up. They haven't overtaken Cauda equina in terms of the numbers, but they have overtaken them in terms of the payouts. If you look in the literature for the clinical features of spondylodiscitis, you'll see this triad of pain, fever, and neurology. But as these cases show, and the more recent evidence states, there isn't always this trio. Pain is focal and generally worsening, and worse at night, but this could account for a lot of other conditions. Fever is only present in around 50% of the cases, and neurology is only abnormal if there's an extension into the epidural space, which is around 30% of the cases, slightly higher with those with an epidural abscess. Again, the associated symptoms are very vague. NHS resolutions have done some work into increasing health-seeking behaviour, which is significantly higher, both in A&E and primary care prior to diagnosis. What I feel is more important is the epidemiology of these patients. It is more male to female orientated and increases with age. The risk factors there are the common findings with our patients: diabetes, including poorly controlled diabetes, and risk factors bacteremia are high on the list, as well as things like other foci of infection, including infective endocarditis, dental abscesses, or any metalwork that's been put in recently that may well be infected. Most of the guidelines suggest that patients will have a spinal infection and will have at least one of these risk factors. In terms of diagnostics, biochemistry is very important. Using CRP or ESR is generally advised, even though it has a low specificity, it has a high sensitivity in these cases. An MRI is the gold standard in imaging for these patients, and as I mentioned earlier, plain film X-rays shouldn't be considered in trying to diagnose a spinal infection. Blood cultures are generally advised, though they're only positive in about 50% of cases, and that's if you manage to get a blood culture before antibiotics are started. Spinal biopsies are debated as to whether they have a higher yield or not. An evaluation for infective endocarditis in the form of an echo should be considered, especially those with a positive Staph aureus infection. The management is a little bit debated, but it's generally medical management to start with, in the form of antibiotics, and these are started intravenously to start with, ranging between 6 and 12 weeks, depending on the severity of infection and epidural involvement. There are large trials out there, including the Aviva trial, which is looking at oral step-down at an earlier stage and could be considered between 2 and 6 weeks. Bed rest and spinal orthosis are often used in the management of the pain and also the deformity in the early stages. But surgery could be considered for these reasons, including progressive neurology, deformity, any instability, or whether debridement for recurrent or persistent infections is there. Thank you.
Thank you, Tom. My presentation is, again, quite a number of cases. Some of them are interesting. Most of them were referred to our on-call service as query Cauda equinas. And I think it's important to focus on a Cauda equina syndrome because it does cause a lot of clinical problems for patients, and this is irreversible. So I have just an educational contract with DPU, that's all my disclosure. So I'm just going to go through kind of real world kind of problems. There's no highbrow research or anything like this. It's just my thoughts of why we should be focusing on Cauda equina, but also thinking of other things that can cause problems. And triggers, what triggers should we use to investigate? So if, say, for example, somebody comes with a Cauda equina, but it doesn't have a Cauda equina compression, what do we do next? The first one, a 65-year-old male, recently retired, decided to do some gardening, I think in his first week after retirement. Develops quite severe back pain, is on warfarin for some kind of thrombotic pathology. Presents to a peripheral hospital with paresthesia, increasing pain, develops some weakness 6 hours later. 12 hours is catheterized. 24 hours has profound weakness of both lower limbs. And initially just gets an MRI scan lumbar spine. That was reported as not showing any compression. And then about 36 hours later, he presents with a scan that shows quite extensive epidural hematoma. Part of the hematoma was intradural. So spontaneous epidural hematoma is rare, but should be considered in patients who are on blood thinning medications. Diagnosis is rapid with an MR scan, it's quite obvious. And if you do have a diagnosis, an urgent decompression is recommended. This gentleman presented extremely late. He also developed an acute abdomen, and for various reasons did not end up having surgery and was left with a permanent deficit. The second one is present with sciatica, back pain, foot weakness. So you think, okay, this could be related to something going on in the lumbar spine. But the MRI scan lumbar spine shows this small L5-S1, maybe degenerative disc bulge, but no significant compressive pathology. So the patient was discharged home. He presents 6 weeks later with paraparesis to the regional spinal center, and the whole spine MRI scan then now reveals a hemangioma with this mass in the canal. So this is, we see this quite often in MR scans, atypical hemangiomas or hemangiomas of the vertebral bodies. In the vast majority of patients, they are entirely benign and they don't usually cause problems, but they can. And some of them you have to be looking for the soft tissue, as you can see in here in the axial sections. Again, this was, we were not sure whether it's entirely extradural or intradural. They ended up having surgery and they did improve. This lady was seen in and around the time of the pandemic. She's 32, works, is a homemaker, and severe thoracic back pain was her presentation. Initially went to the primary care for thoracic back pain. Initially, they did all the right things, analgesia, some physiotherapy referrals. Subsequently started experiencing severe girdle pain, and girdle pain in my view is should be part of red flags, because I think sometimes it heralds cord at risk problems. And again, she had initially got MR scans of lumbar spine, which was fine, and eventually she turned up in my clinic with a sensory level across a xiphisternum. Motor power was normal, but she had a 6-month-old baby and started developing subjective balance problems. So she was panicking that when she brings her baby down downstairs and she falls, she's going to have a problem with the baby and herself. So she ends up having this. This is a giant calcified thoracic disc with spinal cord compression. You can see the spinal cord is a crescent. Important. So she did end up having surgery, but I just put this slide up because although on an MRI scan, it's quite easy to see where the problem is, but when you are operating on these, you are in danger of operating on the wrong level. So it's important to plan for this by getting the radiologists to introduce a bony marker so that intraoperatively you could identify the levels. Again, these are rare pathologies. but intercostal neuralgia is present in quite a significant proportion of them when they become symptomatic, although a significant proportion will be asymptomatic. So she ended up having surgery through the chest, and this is a post-op two-year post-op MR scan where the radiologists tell us that we need to repeat this because they are not entirely happy with the appearance of the cord, but we'll repeat with an interval scan in the future. Neurologically, she's doing fine. So this is very early on in my career as a consultant. This was in 2009. I remember this lady because there was lots to learn from here. She's a 33-year-old female, presents to a peripheral hospital with severe back pain. English is not her first language, so she finds it difficult to communicate. She did an MRI scan, doesn't show much, small disc. Physiotherapy, mobilize, worsening back pain. She gets referred to the psychiatric team for functional neurological problems, gradually loses the ability to walk, and is labeled as attention-seeking and becomes bedbound. Eventually, a neurology registrar organizes an MRI scan of the thoracic spine. And now this shows a tuberculous abscess, and all hell breaks loose, and phone calls are going, patient in NBM, transfer immediately, etc. She is paraplegic when she arrived. She did undergo decompression, stabilization, full anti-tuberculous therapy. You can see the MRI scan, the axial section also shows the effusion on both sides of the chest. But the beauty of tuberculosis paraparesis is that they do recover because it's a slow process. It's not all doom and gloom. We are seeing a resurgence, I think, at least in our region, in the Northwest. I've seen several now. Multi-drug resistance is a real threat, so it's important to involve the infectious disease team very early on to do all the tests that they can do to make sure that they're giving the right antituberculous treatment for the right time. She regained full function. She came to see me about a year ago with lower back pain, so I took the opportunity to do an MRI scan just to see what's happened with the cord, and the cord looks reasonably okay. Again, this was in 2008. This was a security guard. He was, I think he was from Malawi. So he had come, he was working in Manchester. He got fired for being drunk because he had this lump in the back of the spinal canal, pressing on the spinal cord, taking out his dorsal column. So he's got a broad-based gaze. He walks around like this. His supervisors thought he's drunk, so he fired him. And eventually turned up to our hospital. Initially was reported as being possibly myeloma, but the only slight problem was the destruction that you see on the CT scan, which is at the costovertebral joint. And I call tuberculosis the great pretender because it can pretend as anything. In tumors, it can trauma even sometimes. So again, he underwent decompression, stabilization, biopsy, which confirmed tuberculosis, and he had full AKT. So these are some left field ones. These are more recent. So 61-year-old, this is only about 3 or 4 months ago. 61-year-old male is a vasculopath, had aortofemoral bypass surgery, and gets admitted to a local hospital. It's complete, sudden loss of motor power in both lower limbs and some pain, not a great deal of pain, but some pain. And he's incontinent certainly of bladder. I'm not always convinced of the history of bowel incontinence because I think yesterday it was also made clear that you need to ensure what exactly the patient is describing. Are they describing a loss of fullness of sensation, or is it something different? So this patient was incontinent. Fortunately, the vascular team, although he was referred to us as quericot-Icona syndrome, the vascular team at the same time arranged a post-contrast CT and you can see the pre-contrast CT on the left, and you can see the vessel anteriorly, and you can see the post-contrast where there's a complete aortic block, and this has resulted in a complete spinal cord infarction. So there's no surgery, spinal surgery, that's going to fix this poor guy. So the important thing is so this is another one, 70-year-old female admitted with, again, sudden complete loss of motor function, both lower limbs and bladder incontinence, not very much pain. Now, this is the original MRI scan that was referred and reported as showing the cauda equina. There's cauda equina compression at L4-5 with degenerative grade 1 spondylo. We see this all the time when stenotic patients are referred to us because they are reported as a cauda equina. Yeah, they are cauda equina compression, but they are not cauda equina syndrome. So when I looked at the scan, I generally am very skeptical of stenotic patients suddenly becoming cauda equina unless there's a real good reason. And I was looking at the appearance of the spinal cord that you can just see, and it didn't quite look normal to me. So I held off any kind of surgery, and I phoned a friend. I think friends are important in different specialties when you're doing this kind of work because they are specialists in their field. So I rang a neuroradiology friend of mine. I said, this doesn't look normal to me. What do you think? He said, yeah, it doesn't look normal to him either, and he thinks it's a spinal cord infarct. So scan the rest of the spine. You can see the spinal cord is a bit swollen. You can see a little bit of whiteness in the middle of the spinal cord. And you can see I hope you can appreciate it, but the spinal cord should be much grayer than it is. But this lady had a spontaneous spinal cord infarct. I think sudden loss of motor power with little pain is very rare to have a compressive surgical pathology, I think. I might be wrong, but yeah, if you have compressive pathology, you expect pain. If I had continued to operate on her, then I think the consequences, both for the patient and for me, would have been a bit more worse. I mean, patient is pretty much, she's paraplegic, but if I had done surgery on her and she's expecting to get better from the surgery, and then you diagnose spinal cord infarct after you've done the decompression, then I think it's a bit of a difficult conversation to have with the patient. So I think these are just my thoughts. I think we have to listen to the patient. What is the patient exactly saying? What are they saying? Is it pain? Is it both legs gone? One leg gone? Do they have perineal numbness? What is it about the incontinence that they're talking about? Is it urge incontinence? Can they not get to the toilet in time? Or do they have true incontinence where they have no control? I do think a thorough clinical examination, including not just motor power, but assessment of the spinal cord in its entirety, including the dorsal column, is important. Consider other comorbidities they have. For example, the first patient who was on warfarin. Adequate imaging. If you are referring a patient for query cauda equina syndrome, and clinically you are convinced it's cauda equina syndrome, the MRI scan of the lumbar spine doesn't show compressive pathology. You can't just leave things alone. Because you've got to then say, the patient is still there, patient still has a problem. You've got to try and find out what the problem is. It may not be that they need emergency surgery, they may need treatment. So adequate imaging is important, getting the rest of the spine scanned, or other, like, the vascular studies that that I showed. You have to consider the non-surgical causes of the neurological signs and symptoms that the patient is displaying. It doesn't have to be a compressive surgical pathology. And not, like Tom has shown, not every spinal emergency is query cauda equina syndrome. There are lots of other pathologies that can present as query cauda equina syndrome. although Kodai-Konar syndrome is important. We don't know exactly what the incidence is, but less than 1% of disc herniations or stenosis will develop Kodai-Konar syndrome. This is an article in the British Journal of Neurosurgery. The range is 1 in 33,000 to 1 in 100,000 people per year. So it's a rare condition, but if not diagnosed and treated promptly, can have devastating consequences. High index of suspicion, but always be aware of other equally serious pathology. Thank you.
Does anyone have any questions? Can I just remind you to use the microphones if you have, please?
Thanks very much for a great talk, both of you. I think two things come out really well. Number one, the importance of taking a detailed history, which if we get referrals from other places, we suffer from very poor quality history that is given in the referrals, which makes it mandatory for us many times to actually see the patient ourselves and take history. Are we sure that, to pick up these rare causes that you so eloquently presented, do you think an MR of the whole spine should become a standard protocol for any patients presenting to A&E with these sort of conditions?
I think in the new Kodai-Konar syndrome pathway, if a patient is being scanned for query Kodai-Konar compression, the pathway directs you to do a sagittal T2, I think, screening. But that's only for if you're referring patients for a query Kodai-Konar scan. If you're referring them for something else, then you may have to do this as a separate thing. But most patients get referred as a query Kodai-Konar, but the pathway does cover it as a screening sagittal T2.
The radiologists in oswestry are very skeptical of this screening T2 sagittal because the diagnostic clarity that you get from just a screening T2 sagittal is not going to be good enough. You're going to miss some pathologies. So if you have, say, a lesion presenting to one side, for example, like an epidural hematoma or an old lipoma, something like that in the extradural space, and it's not in the center, because those slices are so thick, you're going to miss it.
I think the protocols have been gone through by the radiology societies of UK, and they have co-badged it. And I get what you're saying. In most cases, it'll pick up, in my view, it'll pick up a surgical large compression of the spinal cord, which needs an operation. It may not pick up the neurological problems, but they are not that urgent. If you still think the patient has got enough signs and symptoms, then you may choose to then say, okay, fine, we need to do a more detailed scan with the T1, T2, STIRS, whatever else is required.
Hi, Jim Warren, I'm a surgeon in Preston. To kind of comment on what Barinder said, I had exactly the same thoughts. Actually, our radiologists instigated that T2 sagittal scan some years ago, and the reason why they did that was because we get patients coming through, query Kodai-Konar, nothing was shown on the MRI scan, which we see a lot of the lumbar spine, and the next thing that we were then requesting was the rest of the spine to be imaged. And so they took it upon themselves to change the protocol of the scans that they did for that very reason. So, get better radiologists.
I think it comes back to that assessment, doesn't it? Getting that really thorough history taking and really critical clinical examination, including all your long track signs, dorsal columns, because that'll give you a hint as to where we should be scanning.
Thank you. Great talk. I'm Sarang Sapare from Sunderland. I just wanted to comment how important lateral thinking is. I had an experience where a patient was referred to our unit with a Kodai-Konar syndrome, young lady in her 40s. She had bowel bladder symptoms, scan done, no Kodai-Konar, ongoing symptoms. Eventually, she sees a colorectal surgeon and she had a rectal cancer. By then, it was late and she passed away, 6-7 months. So lateral thinking is important, I think, as you mentioned.
I agree. Sorry, Arsh, I just want to make a point. If some of you attended the acute referral pathways talk yesterday, you may have noticed that quite a significant proportion of patients that are referred for queriquota syndrome to a central hospital, they never had a scan. And that's the worrying thing for me. I'm sure you've seen Mr. Golash presented that patients were referred in the night for, do we need to transfer this patient for a queriquota syndrome? They said, no, you can get the scan done in your hospital at 8 o'clock in the morning. But then when they went back and looked at the data, those patients never had any imaging. So I just wonder what's happened to them, because the patient are still having a problem, but they don't have a diagnosis. Harshad?
Yeah, I mean, I'll lead on from what you're just saying, that we all suffer from tunnel vision, particularly when there's a busy on-call and the referral is channeled as a queriquota referral. So you are just zoomed on to that aspect. And what we have done further to the BAS and SBNS guidelines is to set up a pathway which makes it mandatory for our trainees to fill an Asia score sheet. And that has allowed us to pick up a slight odd neurology here and there. And in those cases, we certainly get the rest of the neuraxis scanned. I can't quote with evidence, but that has helped. I just wanted to know what is everybody else's view about Asia score, Asia sheets.
I think it may work in the specialist hospitals. I don't know how much it will work in our peripheral hospitals. We don't have any control of the incoming referrals. Who sees them? Increasingly, post-pandemic, what I've seen is patients are, at least and this is just a very anecdotal thing. Please don't shoot me down. Patients are being seen in accident emergency by pre-registration house officers, or nowadays called F1, F2 doctors only. The imaging is reported by an ST3 radiologist. And the only consultant that is involved in any decision making is sitting remotely, which is me, about 25 miles away in a different hospital, looking at some images. Okay, so I think it is important to. Asia chart is good, and we try and use it in our hospital, but I think it's quite. The way our setup is quite impractical for us to expect peripheral A&Es to start using it.
Thanks, guys. I think you've shown how important your reasoning and knowledge is. Do you think there's a risk with all these pathways and protocols that we are diluting the clinical reasoning out there of the clinicians that are assessing these patients and referring them in by giving them a protocol to follow?
Yes, I'm sure that is a very high risk. Everyone's after a piece of paper to follow, do this, follow that. And you need to be aware of all those that aren't going to fit on a standard pathway or protocol that are out there, these presentations that don't fit your features.
I'll make another comment, and I think I'm probably going to get shot down now. But I think we are not Jamie Oliver, but everybody is looking for a cookbook, a recipe. They want a recipe that I want to put this much of sugar, this much of butter, and I'll get a nice patient at the end. It doesn't exist, because every patient is different. And with the pressures on radiology reporting, I would contend that people who are ordering scans need to be able to look at the scans, because the MR scans are being reported as normal, which are not normal, because the radiologists are under so much pressure of reporting the scans. They've got probably few minutes to look at each scan. And I've just done an on-call where a radiologist missed a cervical epidural abscess. I mean, that patient, if you don't operate on them, they are either going to die or they're going to die quadriparetic. So looking at imaging is important, because you look at the report and say, yeah, it's fine, discharge the patient. But actually, when you look at the images, and maybe not, we have to do something more. So protocols are good because they reduce variability. And we know from the NICE guideline protocols that the outcome and survivability of our patients, which we've looked at in Greater Manchester, has improved, because it reduces the variation of treatment. but it should not be the be-all and end-all of treating a patient.
Hi, question for Rajat. Very rarely, I mean, first of all, excellent talk, and you covered actually a wide variety of interesting cases. Just opening some thoughts on think about others, compressive and non-compressive myelopathic causes along with the cauda equina. Rarely you see widespread epidural abscess, or maybe other causes with simultaneous compression of spinal cord and cauda equina, and both needing operation, and you feel that one should go for, say, one first, so which one you do first if you, say, decompress and treat cauda equina?